Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a discussion on cortical mastoidectomy. In my previous class, we spoke about canal wall up and canal wall down procedures. What are these procedures and what are the differences between them? So today we'll start discussing one of the most common mastoidectomy surgeries that is done, and that is cortical mastoidectomy. You can also purchase my notes now. I have added links in the description. Okay, so let's get started with what is cortical mastoidectomy. So, cortical mastoidectomy is the complete exenteration of all the accessible mastoid air cells and converting all of them into a single cavity. The posterior meatal wall is left intact and middle ear structures are not disrupted. So these are some key words to remember over here. So cortical mastoidectomy is an example of canal wall up procedure where we remove all the accessible mastoid air cells only and convert them into a single cavity. Important part to remember here is that the posterior meatal wall is left intact and we do not disrupt the middle ear structures. You can see in the image over here, this is anterior, this is posterior, this is superior, this is inferior. This is what cortical mastoidectomy cavity will look like. You can see that this over here is the dural plate, this over here is the sinus plate, this is the sinodural angle, which is also known as a Sittelis angle. Then the lowermost inferior part is formed by the digastric ridge, and anteriorly we can see the posterior meatal wall. And the structures that you should be able to see are the lateral semicircular canal, the incus over here, and the Trotman's triangle over here. And through the Donaldson's line, you'll be able to see the endolymphatic sac. So, cortical mastoidectomy has three other synonyms. So, it is also known by Schwartz operation. This is because it was first described by Schwartz in about 1873, I think. It is also known as complete mastoidectomy or simple mastoidectomy. So, this is what cortical mastoidectomy is. Now, what are the aims of this surgery? First of all, the first aim over here is to eradicate disease from the mastoid air cells. Second would be to create a pathway for drainage and aeration between the mastoid adytas antrum and the middle ear. And lastly, the aim is also to preserve the middle ear structure and the hearing status of the patient. So these are our three aims of doing a cortical mastoidectomy. Now, next, we need to know what are the indications of cortical mastoidectomy. So, the first kind of indication is when there has been an involvement of the mastoid in a disease. For example, one would be acute coalescent mastoiditis with or without the presence of any subperiosteal abscess. Second would be the second type of mastoiditis, which is masked mastoiditis. Third is any case of acute otitis media. Sometimes what happens is, in a case of acute otitis media, say this is a tympanic membrane, there's a small perforation and there's a lot of collection of pus inside the mastoid posteriorly as well as the middle ear on the medial aspect. Now, through this pinhole perforation, enough of it is not being able to drain out. So, sometimes we can see acute otitis media with a sign which is known as the reservoir sign. So, when in cases of acute otitis media, which is presenting with reservoir sign, and on treatment with antibiotics, it is not getting resolved, in those cases, we perform a cortical mastoidectomy. Next indication is coming to CSOM. Now, CSOM mucosal type, when there's a sclerotic mastoid and there's a persistent infection which is not responding to any medical treatment, you will also perform a cortical mastoidectomy in such cases. Fifth indication is a case of cholesteatoma. However, this has to be a very, very limited cholesteatoma only to the mastoid antrum and adytus. If it is beyond this, or if while performing the surgery, it is discovered that the extent of cholesteatoma is way more, the surgery can be converted into a canal wall down procedure as well. Lastly, the next set of indications is when it is performed as a part, as an initial step to another surgery. For example, it is an initial step to endolymphatic sac surgery or for decompression of facial nerve or it could be for surgeries of acoustic neuroma in cases of translabyrinthine or retrolabyrinthine approach. It is also a part of the cochlear implantation surgery, or it can also be used for access to the inner ear to perform labyrinthectomy. This can also be used for access to the CP angle, the skull base, and the petrous apex. And lastly, cortical mastoidectomy is also done as a part of combined approach tympanoplasty, which is also a canal wall up procedure in mastoid surgery. So these are all the indications of performing cortical mastoidectomy. Next, coming to contraindications. Now, most common contraindication here would be if the patient is unfit medically to be taken up for surgery. Second is any condition that may require a canal wall down mastoidectomy, you should definitely not be performing a cortical mastoidectomy. For example, if the cholesteatoma is very extensive, or say if the patient the patient that has come to you is probably showing chances of unreliable follow up. In these cases, we do not perform a canal wall up mastoidectomy. Third, if there is a posterior canal wall defect which cannot be reconstructed, in that cases you should definitely be doing canal wall down surgeries. So these are some of the contraindications of cortical mastoidectomy. It is important to remember that any active infection of the ear and otorrhea, which is ear discharge, these are not contraindications to performing cortical mastoidectomy. However, after admitting the patient, you should definitely try to treat the ear infection and make the ear as dry as possible preoperatively. So, this is very important to remember over here that these are not contraindications. Now, let's move on to discussing the different steps of surgery. Before we discuss the steps, first thing to know is that we prefer using general anesthesia for these patients. Next, coming to the position of the patient usually lies supine with their face turned to one side. Say you're performing surgery of the right ear, the face is turned towards the left side, and the right ear, the ear which is to be operated, is directed upwards, facing towards you. That is the position of the patient. Next, coming to preparation. So, for preparation, we'll be first of all, we'll inject local anesthesia. So, we'll be injecting the tragus as well as the postauricular skin with 1% lignocaine in 1 lakh adrenaline to provide hemostasis and local anesthesia. Second, the external auditory canal as well as the tympanic membrane is first examined. Then it is irrigated with saline and cleaned off any debris that might be present. And then we inject the external auditory canal skin with lignocaine and adrenaline in the posterior, inferior, and the superior quadrants. So, this is all about how we prepare the patient for the surgery. Now, we'll discuss the different steps of the surgery. So, first of all, is our incision. So, usually we use a Wild's post-auricular incision. Here we give a curved post-auricular incision. If you look in the first image over here, a curved post-auricular incision which is made about 1 centimeter behind and parallel to the retroauricular sulcus. So, this is the retroauricular sulcus, about 1 centimeter parallel and behind to it. We give this post-auricular incision. It starts from the highest point of attachment of pinna and it continues down towards the mastoid tip. So, this is our incision to begin with. It is important to remember here that we do not give this incision at the level of the sulcus, because if we do that, first of all, it will be very difficult for us to close the suture lines. And then, even after that, as the scar keeps healing, that may actually lead to deepening of the retroauricular sulcus. So, we definitely need to remember that we have to put the incision 1 centimeter behind and parallel. Second important thing to remember is in cases of children. In cases of young children, their mastoid tip is not very well formed. So, in our cases, we know that the facial nerve exits the temporal bone through the stylomastoid foramen. So now this is the location of the mastoid tip, right? So this is the stylomastoid foramen through which the facial nerve comes out. Now, because the mastoid tip is not fully developed, so the facial nerve is now in a more superficial position and therefore more prone to getting injured in cases of young children. So in these cases, we need to remember that we'll change the incision slightly. So if you look at the image here, A is the incision that we usually give, the post-auricular incision in an adults. But in cases of children, we'll try to give the incision in the direction of this line marked as B, where we basically bring the lower end of the incision more posteriorly so as to avoid any kind of injury to the facial nerve as it's exiting through the stylomastoid foramen. So this is the important bit about incision that we need to know. Next, as we give the incision, we cut through to the soft tissues and reach the periosteum. Now, once we reach the periosteum, we'll have to work on the next step, which is exposing the mastoid cortex. So, how do we do that? Let's look at the second image over here. We see here that there is a T-shaped incision that we give over here on the mastoid periosteum and expose the mastoid cortex. So the T-shaped incision is, first of all, we give this horizontal incision which is made along the linea temporalis to the level of the underlying bone. And this incision should be superior to the level of EAC which is in front over here. If not, then it will not lead to adequate exposure of the middle ear. Second, the vertical incision is this second incision is a vertical incision, which is again a periosteal incision, and we make it as perpendicular to the first incision that we have given, and then we carry it down towards the mastoid tip. So this is the T-shaped incision that we have given. Now, once this incision has been given, we take a Lempert's periosteal elevator and we start elevating the periosteum. So the level of elevation would be superiorly over the tegment, posteriorly over the sigmoid sinus, and anteriorly to the level of the external auditory canal. So as you can see in the image over here, this is the linea temporalis. This is the mastoid tip. The posterior extent would be the sigmoid sinus, and anteriorly would be the level of EAC. Now, after you have exposed the periosteum and exposed the cortex, now we put two self-retaining Mollison's retractor perpendicular to each other and expose this entire area of the mastoid and external auditory canal. So now we have proper exposure of the mastoid. So next step over here, this middle ear dissection step, this is usually not a part of cortical mastoidectomy. This step is only taken when we are combining cortical mastoidectomy with tympanoplasty or when we are suspecting that there is disease which is extending into the middle ear. Usually, in cases of cortical mastoidectomy, the disease is usually limited to the mastoid. So, in these cases, we do not perform this step at all, the middle ear dissection. So, if we do perform middle ear dissection, what we'll do over here is the tympanomeatal flap is elevated and we dissect it from the ossicular chain. Then we'll assess the extent of the disease and what is the ossicular chain status. And if we find any cholesteatoma, we dissect it from the middle ear and remove it. So this is about the middle ear dissection. So now that we have exposed the mastoid cortex, the next step is to identify the mastoid antrum. In a previous class, I have already discussed in the last class that the mastoid antrum, to determine it, the landmark for it is to find the suprameatal triangle or the McEwen's triangle. Now, once we find the McEwen's triangle, we know that the mastoid antrum lies 12 to 15 millimeter deep to this triangle. So in this image over here, this is the image where we see, where is the McEwen's triangle. So once we have found the McEwen's triangle, we start going deep to this McEwen's triangle. So we start removing the mastoid cortex over here with our burrs. Now, as then the next thing is we end up reaching the mastoid antrum. Very important thing to remember here is something called as corner septum. So sometimes we may end up coming across this corner septum. What is corner septum? It is the septum which actually may seem like once you reach the corner septum that you have reached the antrum, but if in case a corner septum is present, that means you have still not reached the antrum. So corner septum is this septum between the squamosal and the petrosal part of the temporal bone. So once you remove this septum, Once you're using your drill to go through the septum, that's when you end up reaching the antrum. So it is very important to be able to identify the cornus septum and remove it to reach the antrum, because sometimes if you have not identified the cornus septum and it remains, and you think that you have reached the antrum and cleared out all the disease in the antrum, you'll actually be leaving behind disease and there will be recurrence of the disease in your patient. So it is very important to be able to identify cornus septum. So now that we have reached the antrum, our next step is to remove all the mastoid air cells. So any accessible mastoid air cells are all removed, and even the zygomatic cells in the root of the zygoma and the retrosinus cells behind the sinus, between the sinus plate and the cortex, are also removed. Now, lastly, we also go towards the tip of the mastoid. If you see in the image, this is the tip of the mastoid. You remove the lateral wall of this mastoid tip as well, and that exposes the muscle fibers of the posterior belly of digastric. So, this is our inferior limit. So, this step is all about removing any accessible mastoid air cell that you can remove. So, this here is when we reach the limits of cortical mastoidectomy. So it is important to know what is our superior, inferior, anterior, and posterior limits while we are performing cortical mastoidectomy. Let's look at the image over here. So our superior limit would be the tegmen tympani or the dural plate. We should not breach this at all, because then we'll end up reaching the dura and end up injuring the brain. Next, an inferior limit is the digastric groove, which we just discussed above. When we try to expose the tip of the mastoid, we drill through the lateral aspect of the mastoid tip to reach the digastric groove. That is our inferior limit. Next, anterior limit is the posterior meatal wall. So, this is our anterior limit. This is a very important part of the surgery where we do not remove the posterior meatal wall. And lastly, the posterior limit is the sinus plate or the of the sigmoid sinus. So this is our posterior limit, and at the junction of this dural plate and the sinus plate is a sinodural angle, also known as Citilis angle. So this is our limit of performing the cortical mastoidectomy. In all of this, we also identify the lateral semicircular canal, which is a very deep landmark. And if you see in the second image over here, right over here, this is the lateral semicircular canal over here, which is placed very close to the incus buttress. So this is what our exposure of cortical mastoidectomy looks like. So you can see the digastric ridge here. Anteriorly is the posterior meatal wall. We'll also have the facial nerve passing down. So we'll have to make sure that we do not damage the facial nerve. We expose the lateral semicircular canal. Then there's the posterior semicircular canal, and we also look at the Trotman's triangle and the endolymphatic sac area over here. This is our sinodural angle, this is our sinus plate, this is our dural plate. So these are all the structures that you will be able to see at the end of performing a cortical mastoidectomy. Once all of this has been identified, we saucerize the edges of the mastoid cavity so as to form a smooth and white cavity. And after doing this, we'll do wound closure. So we'll clear out first, irrigate the mastoid cavity thoroughly using saline and remove any bone dust. And then we'll close the post-auricular incision that we had made in 2 layers. And lastly, we'll apply the mastoid dressing. So these are all the steps of cortical mastoidectomy that you need to know about. And what are the limits of cortical mastoidectomy? Lastly, in these cases, what kind of postoperative care do we take? So as we know that we have applied the mastoid dressing at the end of the surgery. This dressing is usually removed after 24 to 48 hours, and we'll advise the patient to keep their ear dry. It is very important to do that, and so that they also take water precautions for 6 weeks. Next, the antibiotics that you usually give before surgery, these antibiotics are continued for the next 7 days, and even analgesics are prescribed. The stitches that we have put are removed about 7 days later. We perform our first otoscopic examination at the end of 3 weeks and check for any kind of infections or granulations. And lastly, we'll perform a hearing test at about 6 to 8 weeks after surgery. So that's all the post-operative care that you take. Next part of this is would be the complication of the surgery, which I will be discussing separately, where I'll make a topic on all the complications of mastoidectomy and we'll talk about it over there. So that's all for today. I'll see you in my next class. Thank you.